Now, the right vein comes off at the 10 o'clock position sonographically, well visualized here. We do see cases where the reflux is isolated in this vessel, and that's in the absence of any compression of the left renal vein and competency of the left ovarian vein. And there are numerous causes. Primary valve incompetence, there could be some anatomical variants, atypical venous drainage patterns, right? There's idiopathic origins and genetic predisposition. But what we also see is where the right ovarian vein becomes grossly dilated, and this is because of compensatory flow coming over from the left side and draining over into the right. So be aware of this. Now, transvaginal duplex ultrasound, excellent imaging modality for visualization of the ovarian veins and the internal iliac veins. You can see the pelvic varices extraordinarily well, has a 95% sensitivity for pelvic insufficiency. And if you're performing this exam and you become proficient, excellent. But if you are, sending this examination, then few things to think about. You want to be specific as to what you're ordering, and make sure that they use the color flow and that they have the patient bear down, do a Valsalva maneuver as you're seeing here. So again, you get the clinical information that you want, and they're right, very important. Now, when we perform these transpelvic duplex evaluations, the patient comes over to the lab. We have them drink 32 ounces of water. And then once the bladder starts to descend, this is where we can see the pelvic varices. We have a cutoff of 5 millimeters and greater. So you want to measure them. You could change the patient's position. You could use Valsalva maneuver again. You want to demonstrate that reflux. And then you want to also look for peri and transuterine veins. Very important.